Okay, mission education, perfect. Let's move on. Warfarin therapy. Highlighted that in red, but indicated in the prophylaxis and treatment of venous thrombus, pulmonary embolisms, atrial fibrillation, and prosthetic valve replacements. We put it here because we're going to stress it on that prosthetic valve replacement. That's the kind of mindset that we're thinking about. We also talked about HFib a little bit, but for the most part, prosthetic valve replacements. They're going to be on lifelong therapy of your warfarin or your Coumadin therapy when they have a valve replacement. Initially, they're going to be on some type of dual therapy with this in order to get a Coumadin to a therapeutic level. Once they get the Coumadin or the warfarin to a therapeutic level, then they'll back off on that other anticoag and not worry about it anymore. With our warfarin therapy, the big thing is going to be that INR, that international normalization rate, the INR, that's the big one. They'll also talk about a PTT and a PT as well, your prothrombin times, your clotting times, but we're mostly going to measure that international normalized ratio. Normally, me and you, INR, 0.8 to 1.2. Your therapeutic range is going to go up from there a little bit, but with our valve replacements, we like it even higher. I don't want a clot from forming along that valve replacement, on that synthetic metallic valve. And so I want their blood even thinner, not able to clot quite as much. And so that's where I'm going to get in that 3.5 to 4 range. This is patient specific and physician specific as well. It's also going to depend on the physician as well. Some physicians like their patients to be a little bit thinner. Some of them like to be a little bit thicker, if you will. But it's also going to be specific on your patient too. So going back to the example of my father-in-law and my mother-in-law. Mother-in-law, her blood needs to be a little bit thicker than my father-in-law's blood. His has got to be a little bit thinner. But he has a lot of other stuff going on, so he needs his blood to be just a little bit thinner. So they go in for frequent INR checks. They've pretty much stabilized it out at this point. They know what they need to take, when they need to take it, and other things that are going to factor in to change this INR up. And so they know how to monitor that appropriately, so they don't have to go in quite as often. Initial management, they're going to have to go in pretty frequently to make sure that the INR stays at the proper level. Usually we're not going to discharge them until we get it to the level that we like. Then we can discharge them on it. All right. There's a lot of factors that are going to go into this Coumadin therapy, into that INR, things that can affect it. The big thing, intent, big green leafy vegetables. I'm not really sure what that is. It looks like a cucumber with a leafy head, but that's what AI built up. So anyway, but green leafy vegetables. Give me some examples of those.
Spinach.
Spinach, good. What else? Turnip greens, gross.
Broccoli.
Broccoli, gross. Kale, collards, all the nasty stuff. Those types of things, okay? Brussels sprouts, cabbage. Liver can affect it too, but mostly those green leafy vegetables. That's what I'm thinking about. Can they have green leafy vegetables?
Yeah.
Am I telling them no?
No.
No, right? They can have green leafy vegetables, but they gotta have it in kind of a modified in moderation, okay? If
Spinach.
spinach, is it spinach?
Yeah.
Okay, spinach. Apparently that's spinach. In moderation. They gotta have their green leafy vegetables in moderation. They can continue eating however they like. They're standardized. If they eat turnip greens once a week, they can eat turnip greens once a week. I can titrate that warfarin around those turnip greens. They're not gonna go on a binge and eat 2 buckets of turnips, whatever they do. Megan.
I remember when my great grandfather had open heart surgery, he would tell us that he had to watch his salt because his blood was too thick, or does that really, or was that interesting?
Salt can play a factor into it, not necessarily with your coagulation, but it's gonna cause so that constriction, you know, what normally salt does. So it's gonna affect other things, causing stress on those valves.
So that doesn't affect your INR, salt?
Shouldn't. But they're not gonna go on the binge of eating whatever. Also though, to take that into account, if they get an INR level that's too high, so the higher the number, the thinner the blood is gonna be. If they get out of this therapeutic range, say they're at like a 6 instead of a 4, then I can tell my patient, hey, eat an extra bowl of coleslaw tonight, because that's got cabbage and stuff in it. That'll help you out. Eat an extra bowl of coleslaw, skip your cumin tomorrow, and then restart back on it. We'll check it again at the end of the week. Just that extra bowl of whatever can get me back into that therapeutic range. And so that's how I can kind of play with this cumin level, with this INR level. So it's kind of a give and take, all right? Eventually, again, if they're good patients, they follow what they're supposed to, they're able to monitor this and do this appropriately without having to go to the doctor every week or so. There's also new machines out there that can actually monitor your INR levels. So it's kind of like a blood glucose machine. They'll stick their finger, it does this little thing or whatever, it tells you what your INR is. It'll report it to your physician, and then your physician can call you and say, hey, you're good, or hey, whatever. It'll also give you a number, and then you can also call your physician and say, hey, this is what my INR is, this is my current therapy, what should I do? They may say, increase your dose, decrease your dose, eat an extra bowl of something, whatever that may be. Okay? So education-wise, that routine lab work, again, monitoring that INR. I can't get this INR too out of whack. I don't want them to get too thin where they're bleeding everywhere. I don't want them too thick where they start to clot and they have a clot develop along that valve. And then what if that clot disattaches from that valve and then it could float anywhere it so chooses? Remember your dietary information. It could be very easy to ask you a question about dietary information. It's very easy to put those in there. Okay? Dental health, again, remember those prophylactic antibiotics. But also, if they're on some type of anticoagulant therapy, what type of toothbrush should I use?
A soft.
Soft bristle toothbrush, right? I'm not trying to brush my teeth so aggressively. Any kind of nick can cause an excessive amount of bleeding to occur because they don't have that clotting factor. Other things, use an electric razor so I don't nick the skin. Your face, your cheeks are very vasculature. So if you even cut yourself with a razor, it could cause excessive amount of bleeding to occur. Remember, dosing is very specific to the patient, kind of dependent on that patient, but it's also dependent on the physician, depending on how thin or how thick that they like their blood. And then ADL, so there's going to be a lot of things that change. Monitor for those signs and symptoms of bleeding, the bruising that's going to occur. Hopefully they don't bump into too many things. Make sure they're a little more cautious when they're moving around. Probably shouldn't play football, things like that. I don't know why you would be a 60-year-old male with a heart valve replacement playing football, but who knows? But there you go. Questions about cumin therapy? Nope. Okay. Shock. Anybody remember what shock's about? Good. Perfusion. What about perfusion? Inadequate perfusion, right?
Obstructed new blockage, hypertrophic blood,
Okay. Distributive.
cardio.
Cardio. It's going to be
Vascular.
Septic, neurogenic.
septic, neurogenic, or anaphylactic. You can break it down that way. So some type of widespread abnormal cellular metabolism where my body is not able to meet the demands. My heart is not able to meet the demands of the body, not delivering the oxygen requirements that it needs. With that cellular metabolism, it goes from aerobic to anaerobic type of metabolism because it's having to rely on other resources because that oxygen is not available for it to be used. With that conversion of the aerobic to anaerobic respiration, that lactic acidosis is going to occur, and that is going to have a big factor on a lot of our other things as well. But remember, some type of perfusion problem that's causing a decrease in that cellular metabolism, that efficiency of that cellular metabolism. We're going to talk about 3 categories. Remember last week y'all talked about cardiogenic shock, so don't forget about that. Cardiogenic shock is part of shock, but we're not going to list it here. So we got obstructive shock. Some reason or another, I've got something obstructing my blood flow, not allowing for adequate perfusion. Hypovolemic shock. I don't have enough circulating blood volume. I need more circulation. And that's why I don't have that adequate tissue perfusion. And then we have what's called distributive shock as well. So that's broken down into septic shock, neurogenic, and anaphylactic shock. I don't know if it was one of y'all or the day cohort, they said that was on their HESI. It said distributive shock instead of it broken down. What do y'all tell me that?
We have that one.
Yeah, okay. It might have been day cohort that was asking me questions about it. But. So again, another definition here. Acute widespread syndrome of acute circulatory failure characterized by impaired tissue perfusion that results in cellular, metabolic, and hemodynamic alterations. Man, that's a lot of fancy words. Altered tissue perfusion. Let's break it down. Let's talk about hypovolemic shock. What type of things are going to cause that hypovolemic shock?
Burns,
Burns. Why?
because the lack of fluid.
Well,
Loss of fluids, right? Big excess loss of fluids. So I don't have that circulating blood volume. Other things, what do you think? Trauma. I'm losing all that blood volume, right? Hemorrhaging. That could be kind of part of trauma as well, but something independent. Maybe I have a hemorrhagic stroke, or I had a AAA, so aortic aneurysm, I lost a lot of blood from it. Maybe I had a recent surgery, lost some blood. Maybe I didn't get my INR checked regularly like I should, and I don't have any clotting factor. Hypovolemic shock can be broken down into absolute loss versus relative loss. So your absolute loss is going to be things like your whole blood and your plasma. You lose those types of things. And then your relative shock is going to be because of the vasodilation that's occurring. And so that vasodilation that's occurring, I have that increased cellular permeability, and so my fluid is shifting out of the vasculature space. All right, so that third spacing, that edema that you see. So when y'all were all in the ICU, except for Stephanie, y'all saw a lot of edema, right? Mm-hmm. Yes, so that can cause some hypovolemic shock. Cardiogenic shock, I put it on there. MIs, heart valve dysfunction. We're not going to get into a whole lot of detail here, but it's up there. Obstructive shock, things that are going to alter tissue perfusion, obstructing them, not allowing it to move forward. So things like a tension pneumothorax, all that increased pressure on my heart is not allowing for that heart to fully expand like it should, allowing to fill up like it should, causing a decrease in my cardiac output because my heart cannot beat as efficiently as it should. So y'all remember about the ventilators. There was a certain setting on there that I talked about that increases that intrathoracic pressure. You remember that?
Your peep.
Your PEEP. Yeah, your peak expiratory pressure. We'll talk about that in a couple weeks. That can cause some things. Other things, heart valve stenosis, good. Just talked that as well. Pulmonary embolism, causing that obstruction of blood flow into our pulmonary arteries. And then cardiac tamponade, very similar for that tension pneumothorax. That increased fluid around the heart is causing that heart to not beat as efficiently as it should. Distributive shock, broken down in 3 categories: septic, neurogenic, and anaphylactic. Big thing with sepsis is infection, system-wide infection that's causing a multi-system organ dysfunction, MODS. We'll talk about that later in the semester. But infection is going to be the big one. What's the #1 cause? A big one.
Something with the kidneys, isn't it?
Something with the kidneys. I like kidneys.
It's a kidney infection. UTI.
UTI, good. All right, probably should know that. Urinary tract infection. So an undiagnosed urinary tract infection. Maybe they just play it off, or they've had frequent UTIs. They think they can beat this one. They'll just increase their fluid intake and hopefully flush their system out, flush out that bacteria. Drink a little bit of that cranberry juice. It's acidic. Maybe it'll clear it up. All right, it's allowing that bacteria to kind of grow, or overgrowth of that bacteria. And maybe at a certain point, my body is not able to fight that infection off as it should, leading to the septic shock. Neurogenic shock, some type of spinal cord injury. Maybe there was some neuro disorders that could cause this as well. Any neuro disorders? Which one? Any example? How about Guillain-Barré? What were you gonna say?
The ICP.
Increased intracranial pressure. You could have that. Yeah. Good. Anaphylaxis. What type of anaphylactic reactions? There's a bunch of them out there, right?
Yeah.
Bee stings, medication allergies, that hypersensitivity reaction. So remember, as we're having that reaction, everything swells, everything vasoconstricts. So it's altering my tissue perfusion because my blood is not able to circulate as efficiently as it should because of that vasoconstriction. We're going to talk about the stages of shock. We have 4 different stages of shock. We have that initial phase, the compensatory phase, progressive, and then refractory phase. Initial phase, you're really not going to see a whole lot of change with it. There might be a little bit alteration in your hemodynamics within your vital signs. It progressively gets worse. When we get to 4, very high mortality rate. Talk about the stages of shock. Like I said again, that initial stage, our body is not going to do a whole lot, but it's doing enough, a little bit, to maintain that homeostasis. So remember, if we have that decreased perfusion, we're going to have that decreased cardiac output. We're going to start to see a decrease in our blood pressure. We might see a little bit of cyanosis within our peripherals, so within our toes and within our fingers. Might start to see some shortness of breath, high heart rate, because my heart rate's trying to regulate itself to increase to get a little more cardiac output, because cardiac output is heart rate times stroke volume. Maybe I'm trying to breathe a little bit faster to compensate. Change my pH level a little bit. So initial stage, really not a whole lot of change. You may not even notice it. It's very subtle. Your patient may just feel a little off, not much. When we get to the compensatory phase, this is when we're going to start to see some major changes. This is when our body is like, hey, there's something wrong. I need to do something about it. Within our sympathetic nervous system is going to alter things, whether it be hormonal, neural, or some type of chemical response to alter throughout our body to regulate our blood pressure, to create more blood pressure, to create more perfusion to occur. It's gonna increase our epinephrine. Our epinephrine is gonna help with the contractility within our heart. It's gonna make it beat a little bit faster, hopefully produce a little more cardiac output, therefore increasing my blood pressure, increasing my tissue perfusion. Other things, norepinephrine is gonna also be produced, which is gonna cause vasoconstriction, right? Remember, we have our vasoconstrictors. We have that norepinephrine listed or Levophed listed. So our body's gonna do that, hopefully causing the shunting of that blood. We have the arterial and venous constriction, shunting that blood back to those vital organs, the kidneys, the heart, the lungs. Your kidneys get real angry real fast when they have any sort of alteration in their perfusion. Speaking of kidneys, the kidneys play a huge role in this as well. So then we have our renin-angiotensin aldosterone system pick up the work as well, that RAS system, all right? So we have the aldosterone and the adrenal glands being produced, and with that, that's going to encourage that sodium and water reabsorption to occur, hopefully creating more volume, more circulatory volume to increase our blood pressure, therefore increasing my tissue perfusion. With the renin being produced, that's also going to create production of that angiotensin II, which is going to lead to vasoconstriction again, causing more blood pressure to occur. The baroreceptors, mostly that's going to be within your heart muscle. The baroreceptors, as they stretch or they shrink, they cause pressure changes to occur, and so they really monitor the fluid volume status of our body. With those baroreceptors, when they detect those changes, those alterations in our circulating blood volume or our tissue perfusion, it's going to detect those changes, and then in response, it's going to naturally vasoconstrict for us to hopefully produce more blood pressure. Once we get past the compensatory stage, we get to the progressive stage. Our body, in this compensatory phase, doing all of this right here, all these alterations, all of these changes, is not able to keep up with the demands of the body. It's not able to produce enough perfusion to hopefully deliver that rich oxygenated blood to our vital tissues. And so it goes into this progressive stage. This is a very serious stage. Once we get to this point, it's pretty hard to get back. It can go pretty easily into that refractory stage. Once we get to that refractory stage, we have that high mortality rate. In that progressive stage, big thing is this second bullet point right here. Tissue perfusion is affected by hypoxia, and cell metabolism switches from the aerobic side, so the use of oxygen, to the anaerobic side, not the use of oxygen. With that switch from aerobic to anaerobic, is going to create that lactic acidosis. With that lactic acidosis, it's going to cause that vasodilation to occur. So it's actually going to do the opposite effect. We want it to vasoconstrict, but instead it's going to vasodilate, so expand those arteries and those veins and those vessels, and that's what's going to decrease our blood pressure. That's why it's very important for that fluid volume status, so the initiation of those fluids, those bolusing of fluids, if we remember from last semester, so we can wash out that lactic acid, but we can also create more fluid volume for better perfusion. Question about the stages of shock. In general, these are going to be what types of signs and symptoms I'm gonna see with each type of shock. Okay, our cardiovascular, we're gonna have things like tachycardia, because my heart is trying to compensate for that decreased cardiac output. Hypotension, of course, that makes sense. I don't have enough perfusion. Decreased preload. I don't have enough circulating blood volume. That preload is how much blood that I'm fixing to perfuse. How much blood is filling up into that left ventricle when it beats. It's sending it out into the body. That preload. Chest pain. Decreased right atrial pressure. What's the other name for that right atrial pressure? Not wedge pressure. CVP, your central venous pressure. Okay? Tachypnea, altered mental status. If I'm not getting adequate perfusion to my kidneys are gonna shut down, right? My kidneys are not gonna be happy with me. But I'm also don't have enough circulating blood volume, and am I gonna have adequate urine output? No. Good. What should my urine output be?
30 milliliters per hour.
30 milliliters. What now? 0.5, good, to 1.5 milliliters per kilogram. So about 30 mils an hour on the low end, 60 mils every 2 hours. All right, treatment. Big bold and red here. Medical management of shock. Remember, we're trying to improve that circulating blood volume, therefore helping with our tissue perfusion. Once we have gotten that on board, or kind of in sync with what we're doing with this, we've also got to treat that underlying cause. So if we've had a hemorrhage and we're losing a lot of that blood volume, no matter how much fluid or how much blood we pump back into them, we're still not going to adequately restore that circulating blood volume. We've got to treat that hemorrhage before I can correctly treat my patient. As far as fluid management goes, in that obstructive shock, I may have enough circulating blood volume. I've just got to get rid of the clog in the system. I've got to get rid of that clot. Whatever is obstructing, I've got to get rid of it to restore that blood flow, circulating blood volume. Once I remove that, I might be able to restore that circulating blood volume and not need any fluid resuscitation. Otherwise, I'm going to administer some type of crystalloid. What's an example of a crystalloid? So just like normal saline, right? Or LR. How fast are we pushing these? How fast are we administering this fluid?
30 mil per kg.
Bolusing, right? We're going real fast. Chuck says 30 mils per kg. Yes. All right. So let's say I've got a 200 kilogram man. That's a lot of kilograms, right? Big old boy, right? 200 times 30 is what? 2,000.
6,000, my bad.
6,000. Now you got to get 6,000 milliliters of fluid. That initial resuscitation is going to be in that first 1 to 3 hour time span. We're really bolusing these fluids in. Okay, as the patient tolerates it, though. All right. If my patient cannot tolerate 6 liters of bolus fluid, probably don't need to give it to them. Fluid volume overload is a bad thing as well. So we have to make sure our patient can tolerate this large, excessive amount of fluid. With that, how do I know, or how can I tell that my fluid resuscitation was successful? I heard blood pressure.
Map goes up.
The MAP goes up. What do I want my MAP greater than?
65.
65, good. Or, for any neuro injury or neurogenic shock, I want my MAP greater than 85 to 90, because I want increased perfusion to those, to like the spinal column. So we may up their goal to adequately perfuse the brain and the spinal column. So we may increase that MAP. Yes, increased MAP. What else can I tell?
Cap refill.
Capillary refill, I might get better perfusion from that, good. What else?
Decreased heart rate.
Decreased heart rate, okay. What about my CVP?
6.
2 to 6 is my normal, all right? If I give 3 liters of fluid and their CVP is still at 2, did I give enough fluid? Might need to give a little more, right? Okay? What about my urine output? Is that gonna tell me anything? That's gonna make sure I know that I have adequate perfusion to my kidneys. If my kidneys start to like the amount of perfusion that they have, they should produce more urine. Plus, I have enough circulating volume, they should be able to excrete that amount of volume as well. So that's why it's important to know that 30 milliliters per hour, at 0.5 to 1 milliliters per kg, roughly 30 mLs an hour. Okay. If all these fluids do not work, I'm not gonna see those things return to normal, right? I'm not gonna have a MAP greater than 65. I'm not gonna have adequate urine output. My CVP reading is gonna be off, all right? So then what is my next goal gonna be? If fluid resuscitation management is not successful, what am I gonna go to? Vasopressors, so pharmacological management, this next one. So I would know that if my fluid volume is off, maybe I need to consider one of those vasoconstrictors. So good examples are gonna be what? Norepinephrine, good. There's 2 others, vasopressin, epinephrine. There is 5 total.
Phenylephrine.
Phenylephrine, you got phenylephrine, you got norepinephrine, vasopressin, epinephrine, and you have dopamine, okay? And then there is a new one that has been in the works. I haven't seen it used a whole lot, but you might start to see it. It has to do with methylene blue. I can't give you exact details on it, on how it works, because I'm not very familiar with it. They've used it on a few patients, I believe, in CVICU, but somehow or another, the methylene blue causes an increase in blood pressure, which is pretty cool. I have to do some more research on it to give you a good answer on that, but it turns everything blue, but it helps out with your blood pressure. And then a lot of your ICU nurses says the 6th or the 7th blood pressure or vasoconstrictor now is Jesus. So once you get to 5 vasoconstrictors, that's all the drugs that we have currently to constrict down your vessels to help out with blood pressure. You are pretty much at a point of no return. I don't really see a whole lot of patients come back from being on 5 pressors to coming down to 9. The patient in the ICU, he was on 4, which is a lot, but he had a lot of other issues with it, so who knows what's gonna happen with that. Again, did he? Yeah. Okay, there you go. So we won't do a whole lot of detail on the patient. If you know, you know. If you don't, then we won't talk about it HIPAA-wise. But so our goal with our vasoconstrictors, remember our MAP is greater than 65. Our neuro patients, we're going to want it a little bit higher. What kind of complications can I have with my vasoconstrictors? Cutting off circulation, right? And so you were pointing to your fingers and to your toes. Remember, we're constricting those arteries, those tiny little vessels at the very end of our fingers. Right? They're constricting down so much. We're essentially cutting off that blood flow to those fingers and to those toes. So we might have a little bit of necrosis that has developed. And maybe they've had a clotting factor develop as well. And so then as that necrosis starts to get a little worse, we're starting to see those black fingers, the black toes, the levo toes. You'll hear that a lot, and you'll see it. And so they may lose their fingers and may lose their toes from being on a vasoconstrictor for a long period of time, especially the more vasoconstrictors that you get on. But you're alive, so you have to take it. I mean, I'd rather be alive and not have a few fingers. Okay? I gotta have my left pointer finger though, because that's my trigger finger. So I guess I could shoot right-handed if I had to, but Other options, antidysrhythmics. If my heart is in some type of either a lethal rhythm or just like an AFib, RVR, that's gonna decrease my cardiac output. So I want to prevent that from occurring. Or if it is occurring currently, I need to get them out of that rhythm. I don't need anything that's going to count against me as far as my cardiac output goes. My cardiac output's already decreased. I don't need to decrease it even more. So something like an amiodarone or a lidocaine, a digoxin, maybe a beta blocker to slow the heart rate down just enough. And then I could do something like an inotrope to help with what?
The contractility of the heart.
Good, the contractility of the heart. Allowing my heart to beat a little better, more efficiently, however you want to say it. Allowing that heart to circulate that blood flow a little bit better. All right, what's a good example of inotrope?
Dobutamine and milrinone.
Dobutamine and milrinone. So when I think about dobutamine, I'm thinking about the B in there, the beating of the heart. It's helping the beating of my heart, the contractility of my heart. Dr. McCarty talked about it last week too, about the dosing and that kind of stuff. So just think about that. That's what we're talking about here, the inotropes. Thinking about that cardiogenic shock in general, helping with that tissue perfusion. Oxygen and ventilation as necessary. Okay. So if fluids don't work, I'm going to what?
Vasopressors.
Vasopressors, good. I have other things too to help out with my cardiac output and my perfusion. Antidysrhythmics, inotropes. Please know those things. Questions about shock? Nope. Okay. Let's do a quick review on venous access devices. Dressing changes, how often?
Every week.
7 days.
Every 7 days or as needed, okay? I'm not going in there every day just because, right? That's introducing more infection into my system if I continuously change that system or continually change that dressing. So every 7 days or as needed. Now, if it's in the femoral, we're gonna change that Q shift or per facility policy. Or if they have a big, heavy gauze dressing on there, I wanna change it because it's harboring all that bacteria underneath that gauze. So I wanna change it more frequently with that. What type of venous access devices do I have? PICC line, all right, so let's talk about a PICC line. Where's the PICC line entering?
Basilic or cephalic?
Basilic or cephalic vein, right? Going up, terminating into the
Right atrium.
superior vena cava or the right atrium. Good. All right. How often again on that dressing change?
Every week.
Every week or as necessary, right? Is it a sterile procedure when I'm changing that dressing? Should be, right? Okay. So remember your sterility steps. All right. Making sure you're wearing a mask, that kind of stuff. Wearing the sterile gloves, the proper procedures of cleaning, that kind of stuff. With your PICC lines, can they use their arm?
Yes.
They can use their arm, right? All right, can I get a blood pressure on it?
No.
No.
Probably not, right?
You always should.
Probably shouldn't, exactly. So there's no restrictions on that PICC line. Non-tunneled catheters or central lines, triple lumen catheters, all right? What's special about these? Anything? They have the points of termination, right? Good. So compatibility is not really a factor in this. I can just put it up to a different port and it'll terminate in a different part along that catheter. Again, it's gonna terminate within that superior vena cava or right inside that right atrium. So I can actually get a CVP off of this as well. You can't get a CVP off of the PICC line because it takes so long to get to it. Remember, we're going a further distance with the PICC line. The central line, usually we're gonna get into the right internal jugular or the subclavicular, so right underneath that clavicle. And that's where we're gonna place these. Are they heparin locked or not?
Yes.
It depends.
I see
For the most part, we're gonna say they're heparin locked. We're gonna just assume that they're heparin locked, okay? And so when I'm accessing these, what's important?
Make sure you draw
waist.
that.
So draw back or waste or aspirate that heparin first before I give any of my medications, right?
Mhm.
Okay, so let's remember how we're gonna proceed with that. And then at the very end, I need to what?
Flush, and then have.
Flush it and then hep lock it again, right? Okay, as we're placing these, can I place a central line?
No.
No.
Can I place a PICC line?
Depends on if you're trained.
If you're trained or not, right? So, if, just assume you're not trained, we're gonna get something a little bit, somebody else to do it for you. But just because they're getting it placed and I'm not able to place it, does that mean I get to leave the room?
No.
No.
No, alright, so what's my role when I'm placing a central line? Assisting, being kind of the workhorse, alright? Maintaining sterility. Can I get consent?
No.
The physician can get it, but then I can go back through and grab it afterward, right? Making sure the consent is signed, all right? I can prep the patient, right? What position do I need to be in?
You or the patient?
The patient, sorry. Yeah, not me. If I lay flat next to my patient, that'd be a little weird. Yeah, so they're gonna have them tilted down just a little bit to hopefully dilate some of those vessels out. But if your patient can't tolerate it, as flat as they can, all right? Can I go ahead and prep the skin?
Yes.
Yeah, right, I can clean the skin, right, I can shave it if I need to, okay? As they're inserting that central line, what am I doing then? Watching the vitals, what am I specifically watching on the vitals? O2, okay, why?
You don't want to drop too low.
You don't want it to drop too low, maybe we pop the lung, maybe they're not tolerating being flat, positioned, okay? Arrhythmias, good. I'm putting a metal rod or a guide wire into their internal jugular, going down into that superior vena cava, and I might push it too far from the right atrium down into that right ventricle. As that guide wire is in that right ventricle, it could tickle or disturb, whatever you want to call it, that right ventricle, causing a lot of ectopy or PVCs, and I could actually send my patient into VTAC. All right, so I need to monitor those things as my physician is placing that central line. Make sure the physician takes the guide wire back out as he's placing it. That guide wire does not stay in the patient. I've seen that happen more than once. Once that I was not in the room, I was just getting the x-ray for another nurse, and it lit up like the 4th of July. And the other one, I was in the room because it was my patient, and the guide wire didn't come out, and I told him before we did all the rest of the stuff, okay? So the guide wire is kind of important to come out. So that was the non-tunneled side. We have a couple tunneled options that are more protective. So we have things like a port, maybe like a dialysis catheter that's tunneled. Those are more permanent, right?
Yes.
So for instance, like a port, it can stay in forever, can it?
Yes.
All right. Do they need any maintenance on it?
Yes.
They're gonna come in every so often, right? To get it flushed, to get it reheprinized. All right. Make sure they know the signs and symptoms of infection if the port has become infected. Can I access this multiple times?
Yes.
Right, that's the great
The whole
thing, the whole purpose of a port. I can access it multiple times. All right. What type of needle do I use?
Huber.
Huber needle, right? It's a little bit different. She said that fast, she was confident. Huber needle. So we're not gonna throw a blunt tip in there, right?
I hope not.
No blunt tips. We're not just gonna get a 20 gauge IV and just stab them in their port, right? Remember, our goal is to hit the dead center of that port, that kind of gummy little surface area. With that Huber needle, it's specially designed. Huber needle is specially designed to kind of core out a spot, so when you take it back out, that surface reseals and I don't damage that port. Are these heparinized?
Yes.
Yes.
They are heparinized, so remember when we're accessing them, we have to aspirate or pull off that heparin before I give them any type of medication. Remember when I'm accessing these, this is a sterile procedure as well, especially with the dressing changes too, okay? Questions about central lines? Okay. I think that's all I got. your test is gonna be next Tuesday.
Yes.
Please meet in here at 4 o'clock. Don't line up out there. We'll put all your stuff in here. This is a new system that we're doing. Put everything in here. If you don't feel comfortable leaving your stuff in here, we're gonna close the door. If you don't feel comfortable with it, then leave it in your car. We'll give you a chance to go back to your car to get your stuff. We'll allow you to take the test. Once everybody finishes, we're gonna dive right on in to mechanical ventilation. I should release that, hopefully by Friday. If you look at it, whatever, you're probably gonna be studying for your test, so I'm pretty sure you're not gonna look at it, and that's completely okay with me. But remember, we have got to come in here and lecture a little bit after your exam, okay? So your grades are not gonna be released until probably the next day, next afternoon, okay? I know y'all hate that, but it is what it's gonna be. Cause I am lecturing next week as well. When you're going to the